All right, Dr. Irgau, we are live. Good afternoon. It is November 18th, Wednesday, 3 p.m. My name is Kemal. I'm the chairman of American Surgery Center as well as United Medical ACO. This is our weekly live session for patient education. Today we are going to discuss who's a candidate for outpatient surgery. We did discuss this briefly several weeks ago. We are going to bring this back with Dr. Irgau and how we can actually prep you during the pandemic time. We are going to discuss several different aspects of COVID-19 with obesity. So I'm going to have Dr. Irgau to introduce himself. And Dr. Irgau.
Thank you, Kemal. Hello, everyone. I am Dr. Irgau. I am the president of CHRIAS, the Christiana Institute of Advanced Surgery. My specialty, my area of expertise is bariatric surgery or weight loss surgery.
So, Dr. Irgau, I would like to introduce our providers from the program, from CHRIAS. Other than yourself, we have Dr. Gail Wynn, Dr. Mike Peters, Dr. Rose Singh, Dr. George Ibrahim on the bariatric side. And we do have Dr. Sachin Wade for colorectal surgery, and our surgical PA, Sydney Manbach, also is part of our program. So we are going to discuss the, well, before actually we go into this, many of our patients, well, all of our bariatric patients, they do go through the program with the help of the nutritionists, our great team here with Fran, Amy, and Beth, who are part of the program since the beginning of their time with us. And they are supporting our patients while we are going through this. Now, with the leadership of Amy, we have Wednesday wellness webinars from United Medical ACO. One of them is tonight at 6 p.m. We discuss, mainly we discuss issues around diabetes, and any of you who may have issues with diabetes, or if you just want to watch it for fun, if you don't have anything going on around 6 p.m., we'll be on today at 6. Now, Dr. Irgau, I do want us to kind of deal with this issue a little bit differently today. So, including myself from the United Medical ACO, what we tell our patients, okay, well, avoid hospitals during these health crises, the pandemic, COVID-19, coronavirus, whatever you want to call it, we tell them avoid the hospitals. So then we have the issue of surgery, bariatric being classified as elective, as if it was like a nose job or boob job or whatever other jobs. And this, I think many patients are having this dilemma in their mind. Well, one side you tell me that avoid the hospitals. On the other side, you tell me, okay, well, you know, you should have your surgery. Are we contradicting ourselves? Is one of the issue that we would like to, I would like you to address with us.
Absolutely, Kemal. Thank you. I think this issue is definitely pertinent again as we enter another phase during this pandemic, where we are seeing rising numbers, unfortunately, of COVID positive tests, but also increasing hospitalizations. So clearly, if you do not have an important reason to go to the hospital, avoiding hospitals makes sense. And why is that? Well, because sick people will be there. So the chances of actually getting infected are higher. In fact, it's not a surprise that people who work at hospital, people who are on the front line, are at high risk of being exposed just because they are in contact with so many sick people. And then, of course, the other important reason is we don't want people to clutter the system with things that don't need a hospital visit, just because we need those hospital resources for other people, right? So that is really the basic tenet when we say to people, you know, avoid hospitals in general. But that should not be misunderstood into thinking that something that requires treatment should be avoided. In fact, it is very important for people to understand that, yes, there may be COVID patients coming to hospital, but if you are having a heart problem, if you are having a severe abdominal problem, which could potentially be a threat to your life, you have to go to the hospital. It's important. And this message also, it's important that we in healthcare put it out there so people understand that waiting at home with a very serious illness also is not a good option. Now, going back to bariatric surgery and this issue of elective surgery and so, it's interesting because the first time you and I came across this notion was after the initial lockdown in the early months when hospitals started opening up again to do surgeries which were not urgent surgery. They started looking at how to prioritize. In other words, these are the people waiting to have surgery, which one should go? And suddenly we saw that many hospitals were putting bariatric surgery in the back burner alongside cosmetic surgery and plastic surgery. And we said, whoa, whoa, what are we doing here? How can we call bariatric surgery in the same way we classify cosmetic surgery? Well, they would say it's elective surgery. Well, let's not misconstrue the idea. Elective does not mean non-necessary. Elective does not mean the patient has a choice. Yes, you have a choice on whether to have a nose remodeling, face lifting procedure. You have a choice, yes, but you do not have a choice when it comes to treating morbid obesity. You have no choice because the prospect of living with morbidity is a one-way prospect that will take you to more disease and even early death. That's not something that somebody has a choice with. Treatment of morbid obesity is critically essential. So elective surgery in the same vein as procedures like cosmetic surgery is a big, big misunderstanding. And really it comes along this baggage that we've had for many years of considering obesity somehow a fault of a patient and then considering surgery for morbid obesity almost as a cop-out for people who cannot do it without surgery. We have, somebody has a disease, we have to offer treatment. And the disease of morbid obesity comes with many other illnesses that are life-threatening, whether it's diabetic, high blood pressure, and sleep apnea. So I do not have the luxury of choosing of whether to have treatment or not for this. I have to have treatment in order for me to have a healthy life and longer life as well. So to call bariatric surgery as something, as surgery that is equal to cosmetic surgery is a huge mistake. And obviously we cannot give that message to patients.
So, Dr. Irgau, I think it all comes down to the choices of the words that we use, right? So when we say elective, I can't help but just go back to the college years where you take elective classes. So they have only 3 credits instead of 4, right? So everything that's elective is, well, you don't have to do it in some cases. Now, when I was prepping for this session, if you remember our FASMBS this webinar we had right after the pandemic started, there were a group of surgeons who were discussing this and like trying to actually approach the issue from different angles. So when we say we've been actually, this is our volume 12, the one that I'm conducting, but there are more that you guys did. And one of the fight that we are putting out there is the perception of obesity being if it's a chronic illness or if it's not. And then we are saying that this is a chronic illness. This is the science, factual, so it's there. So when we say this is a chronic illness, just like we don't stop treating diabetes during the COVID-19, we are not going to stop treating patients with obesity. So this, like from the risk that our patients are getting, like what we know is, we know that patients with obesity are they're at high risk, right? So we know that. But then we also, I want to share this. This is increasing the risk of hospitalization if they have COVID, if the patient with obesity has COVID, their risk of hospitalization is 3 times more than other patients. Impaired immune functions, decreased lung capacity and reserve, which can make the ventilation more difficult. Now, Dr. Irgau, I would like you to help us, and I prepped this slide for you. So now, because we didn't have time to rehearse, so these 2 blue people are the same people. So this is now, this should say, oh, sorry, this should say after like 6 months. So my idea was, can we actually, let me just fix this so that it's not actually, let me just very quickly fix this. So, it's not,
yeah.
So,
yeah.
So 1 second. So,
yeah. As you're fixing that, Kemal, essentially what we are saying right now is that by itself, morbid obesity is a disease that cannot be overlooked. Certainly, to look at the treatment for morbid obesity in the same way as you would look at things like plastic surgery, cosmetic surgery, is a fundamental flaw. That should really not happen. But let's look at this situation from the pandemic point of view. When the pandemic came, when it hit the world as a very new illness, and we as healthcare workers started to learn about its behavior, about how it spreads, how it affects people, clearly we saw a pattern. We saw a pattern in that there were some people who did not have much symptoms. There were some people who were having a lot of symptoms, and there were some people who were dying from this disease. And it clearly became apparent to us that the people of high risk of dying included people of a certain age, right? Included people with certain illnesses. And guess what? Among those characteristics was obesity as well. It turned out that if your body mass index is higher than a certain point, your chances of getting very sick with this illness, with this coronavirus, and your chances of actually not surviving it increase tremendously. So obesity by itself now suddenly becomes a risk factor for a bad outcome with the coronavirus. So rather than saying, hold off on the treatment of obesity because it's like cosmetic surgery, now this issue of obesity being also a risk factor brings right in front of us the necessity actually of addressing obesity. You're absolutely right. When you put a person who is 310 pounds right now, and they have an option of becoming 215 in 6 to 9 months' time, right? Their risk of really contracting coronavirus and being very sick or maybe even dying from it are much higher with their current weight and much lower with the weight they will have in 6 to 10 months, 9 months' time. And guess what? The difference between the 2 weights is bariatric surgery. Bariatric surgery can take us there. So of all the patients that we have been treating in the last 6, 7 months, Kemal, now those patients are a much lower risk category if they were to contract coronavirus compared to what they were 6 to 9 months ago. That's the reality. So bariatric surgery, let alone being put on the back burner, should be brought right in front as a very important treatment in this situation, not only because it alleviates, diabetes, high blood pressure, and hypertension, but also because it decreases the risk of severe illness or even death when it comes to coronavirus.
So the other thing is that let's not forget the obesity is never coming with no other illnesses. So when we say patient has obesity, we know that patient also has high blood pressure, they have high cholesterol, heartburn, sleep apnea, diabetes. They may have them all, they may have some of those, which makes this even more complicated. Now, let's actually, Dr. Irgau, what I would like to take this from here is to, when we tell people, okay, don't do this, don't do that, and the thing is, we have to have a solution. Then the idea of solution from my side, from our side, is okay. What can we do in a responsible way? When I say in the same PowerPoint, in the same presentation, well, when be careful when you have to go to the hospital during this time, because we want you to be safe. But also, we have all the other stuff to get you ready for it. But then, this is where Ambulatory Surgery Center, which American Surgery Center is, one of the 14 with the certification in bariatric, the Center of Excellence in Bariatric. So we have a program who is specialized in bariatric, which is only in the outpatient setting. But what I was thinking, Dr. Irgau, if you can help us to kind of picture, like you are in the surgery center on a Monday. So help us to tell me like how many patients in the surgery center yesterday, so that we can kind of give the environment that we have while we are doing bariatric cases.
Right. So during that, I was on Monday, we had a total of 5 patients who are having surgery, right? 3 patients were having bariatric surgery, 2 patients were having other general surgery procedures. Now, that by itself decreases considerably the traffic of patients within that setting, right? I mean, this is a healthcare facility, and yet all those nurses, all that facility is focused on only those 5 patients, right? Which means that the chances of getting too many people in one place, right? Back and forth from the preparation area to the surgery place, from the surgery room to the recovery, from the recovery to being discharged, right? If you were taking care of 12, 14, 15, or 12, even 20 patients, the traffic will be much higher. In fact, that's what we used to do before the pandemic, because there was no issue about, exposure to others. But with the pandemic upon us, one of the most important things that we have done to decrease the exposure, not only of our patients, but also of our staff, is to minimize the number of patients. Clearly, this is something you can control well in somewhere like the American Surgery Center. You cannot do that in a hospital setting, because by definition, a hospital is not some place where you come by invitation. You go there if you need to be treated, right? So anybody who's sick is going to be there, right? So the chances of being exposed are much higher in the hospital. So with the availability of outpatient surgery, we are actually achieving 2 important goals. We are protecting the patients from being exposed to the coronavirus by providing this environment. And then secondly, we are allowing them to have the treatment during the coronavirus. So it is a perfect setting, but you have to have a program, experienced surgeons, and a setup like a specialist program like the one the Surgery Center, the American Surgery Center have, for you to be able to duplicate this.
So, Dr. Irgau, the way that I see this, for public to understand, and again, these sessions, in my opinion, it is a great way to communicate exactly what's happening from our side.
Yes.
So we went back to doing bariatric cases after the 5-week break initially. The reason we had that time is because we wanted to see what we were dealing with.
Yes.
When we reopened the cases, we never closed the surgery center because we wanted to be ready for public emergency. Yep, so absolutely. I want to make sure that we keep everything kind of together so that if any of the hospital executives are listening, I don't want them to take this in a wrong way. You and I, we actually reach out to these executives, our colleagues on the hospital side, and ask them if they needed any help, if the surgery centers can be utilized in a different capacity. And the answer was no, they didn't need help. So as soon as we knew that hospitals didn't need our ventilators and other things, then we said, okay, what can we need to focus on, what we can do. Now in our surgery center, we do general surgery cases, we do eye cases, we do colorectal cases. Now, I was thinking what would be a good example for patients to understand is and also like you and I, we actually made another decision today where based on the increased number of cases, COVID cases, we were trying to reduce the number of total cases we are dealing at the surgery center because we want to limit the number of people interacting with each other, and we don't want more than one person in our waiting room in the pre-op PACU, so that flow is almost in a perfect way, it's working. So we then, here's the elective case, screening for colonoscopy. And when I say this, I have to be careful, but screening for colonoscopy because of the age is perhaps something that we can do 6 months from now or 3 months from now, or but because that's not going to increase my level of risk for COVID if I have COVID. Now, I say if I have COVID, but most of the population will have COVID in the next 12 months, regardless of the vaccine being available or not. Everyone will go through this, right? So COVID is not going anywhere. It's just how we are controlling the COVID is the main issue. So then we are going back to just limiting the number of cases, and then we are doing less number of total cases, which allows us to handle our bariatric cases. So that's something that I want to make sure that it's kind of clear. So then there's no misunderstanding, because as we are trying to keep patients away from, even from our offices, unless they have to, so then we have enough room for people who have to be seen. So we are, like we say, like this just brings me back to our digital health record. So when we say here is, we want patients to use the telemedicine, telehealth, take advantage of these sessions. We are saying all this because our offices are still open, and we want our people, our patients, to be able to come to the office in a safe way, where there are, instead of 40 people, we have 15 people, and then we can spread them out in a certain way. So I don't know if I miss anything from our side, Dr. Irgau, but anything you want to add to the issue with the outpatient procedure?
Sure. So, I mean, I hear from colleagues from around the country where bariatric surgeries are being canceled, right? Because hospitals are having emergencies, and these surgeons who have been preparing these patients for months with very rigorous, preparation schedules, now they cannot do the surgery any longer. And that is precisely because they don't have the availability of outpatient centers that specialize in bariatric surgery. And they cannot set them up in 1 minute. It requires a lot of effort, a lot of work, and a lot of preparation to have a functioning, really, really high quality surgery center that specializes in bariatric surgery. And that's what the American Surgery Center is, right? So to be able to do outpatient bariatric surgery center, you need a good program. You need very experienced surgeons. And as you know, we have been doing bariatric surgery now for almost 20 years. We are by far the most experienced group when it comes to bariatric surgery in our area. And then you need a setup within the surgery center where the nurses, the anesthetists, and everybody is really facile with bariatric surgery. They really understand it, and they practice it day in and day out. And that's why we're able to do it. Beyond that, obviously, you have to be able to have measures that allow you to really treat patients and get them to recover fast without too much pain, without too much nausea, and they are able to be up and about soon after surgery. And we have measures and protocols in the surgery center that allow us to do that. Our patients are up and about within about an hour and a half after surgery. And as you know, almost all patients, in fact, in the last year or so, I think, all our patients went home within the same day of having had the surgery, right? And that requires a lot of preparation. So by itself, sending patient the same day home might not have been the goal. The goal was to recover patients quickly. And we have achieved that, right? Patients wake up from surgery and anesthesia without any frown in their forehead now. I see them. Why? Because they don't have discomfort. Because the type of medications we use prepare them really well.
Like increasing the quickness of the recovery is the problem, not to keep the patient in the hospital. But again, these are all the issues, right? The public perception of these. Maybe it's not communicated well. And so what I'm going to go to the time that I was, like, when you were educating me on this, when I said when you say patients can go home safely, I'm like, no, we should keep them. And and that was the perception. What actually forced me to say that was, like, I'm not a surgeon, so why would I need to be making that decision? When the surgeon says, surgeon's comfortable, right? So the last thing that you want is your patient to have some complications. And if the nurses are available, then why would you want them to not stay? But the thing is, what's the issue, like the root of the problem? Again, if we are able to get them recover quicker, then, and if they can actually feel better in their home environment, so why would they need to stay in the maybe not the best place for the patients? Absolutely. If they don't need to be in the hospital? So we go to the hospital when we are sick. We don't want to stay there when we are not sick. So that's, I think
that is actually an important point, if I can pick up on that, Kemal. We go to the hospital when we are sick, right? So the question is, if we give the patient the role of the sick person, if the patient plays the role of the sick person in their mind, they're going to be sick. They're going to recover much more slowly. So if you tell them, okay, you've had surgery, you have to be in that bed, somebody's going to give you everything you need, you just play the sick person, your mind will go into the sickness mode. On the other hand, if you tell them, look, we want you to be up and about. We're going to take care of the pain. We're going to take care of the nausea. We're going to take care of the side effects of anesthesia. But we want you to be up and about. That mind goes into a recovery mode very quickly. So you're actually decreasing the chances of complications by doing that, right? So the safety is there, Kemal, because you're really selecting your patients well. You're doing all your tests at the times that is critically important, right? You're observing the patients. But once all that is done, you want the patient to start recovering, to start going back to their life, as opposed to playing this sick role and be recovering for a much longer period of time. So that's really a big, big difference in the way the expectations are set for the patients.
Absolutely. So I think like we can maybe talk about some of these perception issues in healthcare more and more. So the communication part is the key. We have done so many of these sessions so far. These are on our YouTube channels. And our bariatric events, the webinars, live events, all of them are on the YouTube channel, and then they are categorized in a nice playlist format. So we want patients to take advantage of these, but we at least our main focus is to get you ready when you are the most vulnerable. So how can we get you ready to that time? So then while you are dealing with any of the other diseases, other illnesses, can you be stronger to fight that? And losing weight is going to be the key. And if we were to go back to our patient examples, again, we are not talking about patients who are 10, 20% more than their body weight. We are talking about patients who are 320 pounds, 350 pounds, and they need this help the most. And we want to do this in the safest way. Now, Dr. Irgau, as always, I know you have office hours today. Taking the time is extremely important, and making this event is extremely important. But also, we want this to be safe. And if everyone put their mask on, so I'm going to put mine. So this says, right, Dr. Irgau?
Yeah, absolutely.
Now, the thing is, because I don't go anywhere, Dr. Irgau, so last night I was at tennis, because I don't have the habit of wearing it, because I don't go anywhere. So the problem is it's not like I'm against the mask, because between my office here, my home, this.
Right. Yeah,
so
absolutely.
When I went to tennis after several weeks, I just walked in without a mask. The concerning part is no one stopped me. So then I just realized that I was so embarrassed first. But that kind of reminded me of just reminding people to wear their mask. Absolutely. And having the habit of the mask. So, well, please stay safe. Tonight we have the 6 p.m. event with United Medical Wellness, and Friday we'll do overall updates on COVID and the other things from, again, United Medical at noon. So we have 2 more events this week. And please stay safe until we see you next time. Bye-bye.
Thank you. Bye.